Hello everybody, my name is Mohamed Bahgat. I am Professor of Ophthalmology in Alexandria University, and it's my pleasure to explain in this lecture some of the corneal diseases. So the first part of my lecture will discuss the corneal ectasia or corneal ectatic disorders. We know that the cornea is a transparent part of the outer coat of the eye. It is considered as a part of sphere, so it has a curvature and an optical power which is about 2/3 of the optical power of the eye. The cornea is a regular structure with a diopteric power of about 40 to 49 diopters. So if the cornea is less than 40 diopters, it is called a flat cornea, and if it is more than 49 diopters, it is a steep cornea. So in ectatic disorder, there is increase in the diopteric power of the cornea and irregularity of the surface, which may affect the central part of the cornea in keratoconus, the peripheral part of the cornea in pellucid marginal degeneration, and both the central and the peripheral part in keratoglobus. Sometimes ectatic disorders may be iatrogenic after refractive surgery, such as in post-LASIK ectasia. So the hallmark of keratoconus is central thinning and apical protrusion. So if you want to describe keratoconus in few words, it's enough to say central thinning and apical protrusion. Heredity play about 10 to 15% only in keratoconus. Keratoconus is bilateral, but usually it is asymmetrical. So you may have one eye with early keratoconus and the other with advanced keratoconus. Usually keratoconus starts in the second decade. So what does patient with keratoconus complain of? Due to the steepening of the cornea, there will be decreased vision due to myopia and irregular astigmatism. So what are you going to see when you examine a patient with keratoconus? As I previously mentioned, the slit lamp, on the slit lamp you will see central thinning and apical protrusion. On retinoscopy, you will see distortion of the retinoscopic reflex due to irregular astigmatism. And because keratoconus is an ectatic disorder, there will be increase in the keratometric readings of the cornea. The keratometric readings represent the diopteric power or the curvature of the cornea. In advanced cases, there will be angulation of the lower lid margin on looking down, and this is called Manson's sign. In some cases, you may find epithelial iron deposits on the base of the cone, and this is called a Fleischer ring. The Vogt stria are vertical lines in the stroma and represent undulation of the collagen fibers in keratoconus. So if a patient with keratoconus, what investigations are you going to do? In advanced keratoconus, usually the diagnosis is clinically, and you may not need any investigation to diagnose the case, but investigations may be required in early cases. Investigations are either pachymetry, which is a measurement of the corneal thickness, or topography, which is a map of the corneal curvature, or you may do a pentacam, which is a newer tool that combines the topography and pachymetry and other data to make the diagnosis of early keratoconus possible. So what if a case of keratoconus is left untreated? It may go to some complications due to the progressive steepening of the cornea. This may result in breaks in descemet membranes. So as the cornea is becoming more steep, the collagen fibers of the stroma can accommodate this progressive steepenings, but descemet membrane cannot do this. So breaks in descemet membranes may result. This may result in influx of the fluid from the aqueous humor in the corneal stroma, resulting in corneal edema. This corneal edema may lead to opacification of the cornea. It may resolve in about 1 to 3 months, but leaving a central opacity. So these are some pictures of cases of advanced keratoconus. This is a case of advanced keratoconus, and this is a higher magnification of the same case. You may find the marked steepening of the cornea, thinning in the central area, although the peripheral thickness is okay. There is also opacification of the central part of the cornea. This is a case of acute hydrops resulting from breaks of in descemet membrane, leading to aqueous humor or some fluid in the stroma, resulting in this edematous part of the cornea. This is a picture of the normal topography or the normal pentacam. So the pentacam is divided into 4 parts. This is the topography, which is a map of the corneal curvature. So each point in this map represents a figure of the corneal curvature. So for example, this is 41.4, this is 41.5, this is 42.6, and this is represented by a color coded scale here. So the 42 is green, the 44 is yellow, and if it is more than 50, then it goes to the red color, and it is less, if it is less than 38, which is a flat cornea, it will go to the blue color. This is also a pachymetric map representing the thickness of the cornea in all areas of the cornea. So this is the central area, it is about 510 micron. This is the peripheral area, it is about 500, the paracentral area about 570, and this is the peripheral area, which is about 600. And this is also a color coded scale. So if it is yellow, then it will be 540. If it goes towards the red color, then it is a thin cornea, 380, 340, and if it goes towards the blue color, then it is a thick cornea. These 2 maps are the anterior and the posterior elevation, which is a tool for diagnosis of early keratoconus. So as we can find here, this is a normal topography. All the keratometric readings are between 41 and 42, and the thickness also, the thinnest location here, it is about 510 microns, which is within the normal range. On the other hand, this is a pentacam of advanced keratoconus. As we can see the topographic map, it is towards the red color, and the figures is 75, 84, 61, so it is all about above 50 diopters. So this we call it a steep cornea. Also, if we look at the pachymetric map which represent the corneal thickness, we can find here that the corneal thickness is 367, 379, 418. So there is central thinning and also steepening. So this is a case of advanced keratoconus. This pentacam represents early keratoconus, which you can find that there is some irregularity of the cornea. So we have here the keratometric reading is about 47 and a nearby area is about 44. These dotted lines represent the pupil. So in the pupil you can find many different keratometric readings, and this may lead to irregular astigmatism and image distortion. Also, this is the pachymetric reading, although it is not a thin cornea, but this represents an early keratoconus due to the topographic appearance of the pentacam. So how are we going to treat keratoconus? The treatment should be directed into two lines. First, you must stop progression of the disease, and this can be achieved by only one modality of treatment, which is the corneal collagen cross-linking. The corneal collagen cross-linking, in simple, it is a minor surgical procedure in which we remove the epithelium. We put riboflavin in the corneal stroma for about 15 minutes, and then we apply ultraviolet rays to the cornea. This may result in increasing the strength of the cornea due to increase in the collagen bonding between the collagen fibers in the corneal stroma. The second line of treatment is directed towards the visual rehabilitation. After we stop progression of the disease, this patient, we must find for him a way to see well. He is suffering from myopia and irregular astigmatism, and usually irregular astigmatism cannot be corrected by glasses. We may choose between either doing a rigid gas permeable contact lens. This is a type of contact lens which is hard than the usual soft contact lens. This contact lens will cause flattening of the cone and correction of the irregular astigmatism. However, some patients could not tolerate the hard contact lens due to some allergic disorders of the conjunctiva, or due to some compliance to the way of using contact lens. In these cases, we can use the intracorneal ring segments, which is a plastic segments placed in the corneal stroma, which may flatten the cone. These two modalities of treatment may not be suitable in advanced cases or cases with corneal scarring, and in these cases we must resort to keratoplasty in the form of deep anterior lamellar keratoplasty, in which we remove the whole cornea but preserving the descemet membrane and endothelium to decrease the possibility of rejection. So we do a lamellar keratoplasty. Sometimes we may need to do a penetrating keratoplasty if descemet membrane there is marked affection, such as cases with acute hydrops. So this is a picture of the intracorneal ring segment. As I told you, it is a plastic segments placed in the paracentral area, leaving the pupillary area clear. Putting this segment will cause flattening of the central area and decreasing the amount of irregularity in the central area. This is a picture of keratoplasty, the deep anterior lamellar keratoplasty. This is the graft, and you can see clear cornea. The curvature is very good. These are the sutures. You may use either interrupted suture or you can use continuous sutures as in this case. So now we finished about keratoconus. We will discuss some miscellaneous corneal diseases such as the arcus senilis. The arcus senilis is a peripheral annular corneal opacification occurring in the elderly people. It is not considered a disease, but it is considered a sort of degeneration due to lipid deposition in the corneal stroma. Here we can find that this deposition is separated from the limbus by a clear area which is called the lucid interval of Vogt. It is more common in elderly people, and the incidence in people above 80 is about 100%. So very old people, you can find that the arcus senilis is universal. It may be explained that the blood vessels become more open with age, and this may result in more cholesterol and lipid deposition to leak in the periphery of the cornea. Arcus senilis may occur in young individual, and this is usually associated with some dyslipidemia or lipid disorders, metabolic lipid disorders. The next disease is the band keratopathy, which is a fine dust-like calcium deposits in the subepithelium and Bowman's layer. It is usually a band-like horizontal opacities in the interpalpebral portion. It is caused by systemic hypercalcemia and in chronic inflammation, such as people with chronic uveitis, and also it is common in siliconized eye if the silicone is placed in the eye for long time. The siliconized eye usually when in some cases when we perform vitrectomy, remove all the vitreous to correct the retinal detachment. To tamponate the retina and to keep the retina in place, we inject silicone oil for some time. It's about for 6 months. If this silicone is long standing and it is left more than 6 months or 1 year, then it may cause this band keratopathy. This band keratopathy is superficial. It is at the level of the Bowman's layer and the epithelium, and the treatment is by chemical chelation using ethylene diamine tetraacetic acid, which is called the editor. This is a chelating agent which binds the calcium. So since this is calcium deposit, so you just put editor and the whole calcium will be removed from the epithelium and Bowman's layer. The next disorder is the exposure keratopathy. We know that the cornea should be wetted by frequent blinking. So in some cases there is a disturbance in the blink mechanism of the cornea. This may lead to corneal dryness. So the causes of exposure keratopathy is lack of thalamus as in facial palsy. So here the left eye is closed but the right eye is not closed due to facial palsy. In these cases, since this cornea is not wetted enough by tears and the blink mechanism does not spread the tear film in the lower third of the cornea, the lower third of the cornea will be eroded and may ulcerated and may even lead to perforation. The other cause is lid malposition, such as ectropion. So this is ectropion of the eyelid. So when the upper eyelid closes, it may not come in proper apposition with the lower lid, and this may lead to exposure keratopathy in the lower third of the cornea. In proptosis, there is a combined mechanism. The infrequent blinking may lead to dryness, and also the incomplete closure of the upper eyelid may lead to exposure keratopathy. Also, there are some neurological diseases that may impair the blink mechanism and lead to exposure keratopathy. So the clinical picture of exposure keratopathy is similar to those cases with corneal ulceration, in the form of foreign body sensation, burning, lacrimation, and blurring of vision. Examination will reveal dryness. You may find in early cases superficial punctate keratitis, which may progress to an epithelial defect or an ulcer. Secondary infection may occur and may lead to corneal melting and perforation in this area. So the treatment should be directed to correction of the cause of the exposure keratopathy. Till the cause is corrected, patient must apply extensive lubrication. The upper eyelid may be tapped to the lower eyelid to ensure proper closure, or in some cases you may resort to tarsorrhaphy, which is a sort of suturing the upper eyelid to the lower eyelid. So it can be done a partial tarsorrhaphy. You can suture the part of the upper eyelid to part of the lower eyelid, or maybe a complete tarsorrhaphy where we complete close the upper eyelid to ensure the healing of the ulcer. So here I come to the end of my lecture. I would like to thank you all for your attention, and I'm happy to answer any questions. Usually I'll be in the outpatient clinic on Tuesday. In any Tuesday you can come and ask me any question regarding this lecture. Thank you.